Bismillahirrahmanirrahim. This video will cover the osteoarthritis. The references for this video are these. By the end of this video, we would be able to answer the solution to this clinical scenario in which a 67 years old woman present to clinic with complaints of stiffness and pain in both of her knee. Upon further questioning, she tells that the pain becomes worse later in the day after she has been walking around. These are made for movement and mechanical support. They can be classified as diarthroidal or solid joint and synovial joints broadly, or can be classified as solid bone joints, solid cartilaginous joint, and synovial joint. The solid bone joints are also termed as synarthrosis, and solid cartilaginous joint are termed as synchondrosis. And this classification is based on the manner or type of the material by which the articulating bones are united. In fibrous joint, the articulating surfaces are united by fibrous tissue. Examples for this are cranial bone sutures or syndesmosis, in which two bones are united by a sheet of fibrous tissue. Another example for syndesmosis is dento-alveolar syndesmosis. The cartilaginous joints are characterized by the formation of joint by hyaline cartilage or fibrocartilage. As we know, there are three types of cartilage. One is fibrocartilage, another is hyaline cartilage, a third one is the elastic cartilage. The main difference between the hyaline and fibrocartilage is the amount of collagen fiber which is present. So this fibrocartilage is stiff due to abundance of this collagen fiber, and the hyaline cartilage is soft cartilage due to presence of few collagen fibers. The fibrocartilage is present in symphysis pubis and menisci, while hyaline cartilage is seen in trachea, nasal septum, and end of the long bones. The cartilaginous joints are primary or secondary. Bones are united by hyaline cartilage, which is the example of primary cartilaginous joint. You know that the epiphysis is the place or is the point where the metaphysis and diaphysis are united together. Example of secondary cartilaginous joints is intervertebral joint, in which there is fibrocartilaginous intervertebral disc between the vertebra, and it consists of binding connective tissue that joins the vertebrae together. The third and last category of the joint is synovial joint, in which the articulating bones are united by a joint capsule. This is the continuity of the periosteum. However, the inner side is lined by the synovium. This capsule encircles joint cavity completely, and inside the cavity the articulating surfaces are covered by articular cartilage. All other surface inside the joint cavity is lined by synovial cells. The cavity contains synovial fluid. Synovial capsule is thick, fibrous and smooth, but it is thrown into many fold at the site of its insertion. It is lined by cells without any basement membrane, and this lack of basement membrane allow easy permeability of the nutrient. Under these sinusoids, the tissue is loose areolar, and you can see there are two types of the cells in these synovial lining, which is 1 to 4 cell deep layer. The one is type A and another is type B. Type A are specialized macrophages with lysosomal enzyme and dense bodies, while type B are fibroblast-like cells and they synthesize hyaluronic acid. The synovial fluid provide lubrication, nutrition, and they also ingest debris, and they secrete hyaluronic acid, immunoglobulin and lysosomal enzymes in that environment. The synovial fluid is the fluid which is present within the synovial cavity or joint cavity, and it is clear, sticky and viscous fluid which is present in very little amount within the cavity. It is 1 to 4 milliliter in quantity. It is the ultrafiltrate that act as a molecular sieve. There is no thromboplastin, tissue thromboplastin, so it cannot clot. It contains hyaluronic acid, which is a very large molecule, and because it is highly charged, it has got a high affinity with the water. The articular hyaline cartilage is glistening, smooth, white and semi-rigid. It is not thicker than more than 6 millimeter only, and it basically serves as an elastic shock absorber and wear resistant surface. It is composed of 10% of collagen type 10, while 70% of it contains water. 8% of the articular cartilage contains proteoglycans, and the chondrocytes are also there. The collagen type 2 resists tensile stresses and transmit vertical load, while the proteoglycans are responsible for the turgor and elasticity limiting flexion. Chondrocytes synthesize metric enzymatic digestion and other protein. And important to note that there is no innervation, no lymphatic drainage, and no blood supply for this hyaline cartilage. The articular cartilage is smooth grossly, while on electron microscopy it shows pits which correspond to the underlying lacunae of the chondrocyte. There are 4 zones in the articular cartilage. First is the tendential zone, the uppermost and closest to the articular surface is tangential zone, and in this tangential zone the chondrocytes are elongated, flattened and parallel to the long axis of the surface, and there is condensation of type 2 collagen fibers, hence it is also termed as skin of the articular cartilage. Then the second one underneath this tangential zone is transitional zone. In this transitional zone the chondrocytes are larger, ovoid and randomly distributed. Then the standard hyaline cartilage matrix is here, and on electron microscopy the collagen fibers are arranged transfers to the articular surface. The third zone is the radial zone. Here the chondrocytes are small and arranged in short columns just like epiphyseal plate. The collagen fibers here are large and lie perpendicular to the articular surface. Next is the calcified zone, and this is the deepest layer, and here the chondrocytes are small and heavily calcified matrix is present in this layer. Then the concept of the tide mark. This tide mark is basically a blue line which is shown on H&E stain, and it's a mark of separation between the calcified and the radial zone. This tide mark is the interface. This tide mark is the interface between mineralized and unmineralized cartilage. The area above this tide mark is gets its nutrition by the diffusion, and the area below gets the nutrition by the epiphyseal blood vessels, and this is the area where the cartilage cells are renewed. Under this area there is subchondral bone plate. The tangential and radial zone are the zones which contain highest concentration of the collagen fibers. Unit load is an important concept in understanding the function of the joint. It is basically a compressive force which is expressed as kilogram per cubic centimeter of articular cartilage. It is fairly constant over hip, knee and ankle, and about 20 to 26 kilogram per cubic centimeter. Joint is protected by various mechanisms. One is the adjacent muscles which act as shock absorber and protect the joint. If there is increased unit load on a joint, the joint deformed. So this deformity results in increased contact area of the joint, and this increased contact area will obviously reduce the unit load on the joint. Then interarticular structures such as ligament and menisci also allow two-plane movement, and they reduce the unit load on the joint. Ligaments, tendon, periarticular connective tissue, and nerves, all these are important protective mechanisms of the joint which decrease the unit load or which control the unit load. What happens if there is an injury to any component of the joint? It will result into dysfunction of the joint, and dysfunction of this joint will result in degeneration of other components of the joint, as happens in anterior cruciate ligament. If torn in an athlete, it will result in joint instability, and this instability of the joint will result in degeneration of the articular cartilage. The arthropathies have been divided into four major categories: congenital malformation, deformities and defects, degenerative and traumatic joint diseases, crystal-induced arthritis, and inflammatory joint disease. The group which include these acute and chronic injury, osteoarthritis, and other degenerative diseases such as neuropathic arthropathy, amyloid arthropathy, hypertrophic osteoarthritis, osteochondritis dissecans, and diabetic arthropathy, while inflammatory joint disease include viral, bacterial, microbial, mycobacterial, or fungal joint diseases, post-infectious arthritis, rheumatic fever arthritis, rheumatoid arthritis, seronegative spondyloarthropathies, and other arthritis, which include Beckett syndrome, sarcoid arthropathy, arthritis with primary immunodeficiency, relapsing polyarthritis, and arthritis with generalized immune diseases, while crystal-induced arthritis include gout, pseudogout, and calcium hydroxyapatite deposition disease. For the injury to the joint, it can be acute or chronic. For acute injury, if there is a force applied to the joint, it will result in acute traumatic synovitis, which will result in joint effusion, and finally hemarthrosis is developed. A single acute joint injury is not sufficient enough to produce degenerative joint disease unless there is significant injury to the cartilage, bone, or supportive ligament, or interruption of the joint load or unit load, which we have discussed earlier. While in chronic injury there is damage to the there is repetitive damage, and this repetitive damage, even the injury is minor, but this repetitive damage will result in some degeneration in the articular cartilage and will result in arthritis, and these types are frequently described for elbow, back, hip, and knee, and are associated with the occupation of the affected person. The damage to the subchondral bone is an important factor in the pathogenesis of this chronic injury. Then the arthritis, it is a term which describes inflammation of the joint, while arthritis is plural for this term. Osteoarthritis, which is also termed as degenerative joint disease, is a disease which is characterized by cartilage degeneration that result in a structural and functional failure of the synovial joint. Or you can also say that it is a non-inflammatory disorder of movable joint with articular cartilage degeneration and new bone formation at the joint surface and margins. It is most common type of joint disease, and mostly it is progressive. Then the classification of this osteoarthritis, we can divide it into primary And secondary type, primary type of the osteoarthritis is due to destruction of the joint, which result from intrinsic defect in the articular cartilage itself, and it can be of generalized type and localized type. Generalized type is generalized osteoarthritis with Heberden's nodule, erosive osteoarthritis, endemic osteoarthritis, and osteoarthritis with involved type 2 collagen defects. Then localized type are localized only to a single joint. Then there is a term that is chondromalacia patelli, and this chondromalacia patelli is a term in which the osteoarthritis affects the patellar surface of the femoral condyles of the young pupil. Then this secondary type of osteoarthritis can be divided into various groups. In group 1, there is crystal deposited, such as in hyperparathyroidism, hyperchromatosis, Wilson's disease, gout, calcium pyrophosphate deposition disease, basic calcium phosphate disease, oxalosis. Group 2 is concerned with necrosis or abnormality in the subchondral bones, such as Lippincott disease, aseptic necrosis, slip capital femoral epiphysis, post-traumatic osteoarthritis, Paget's disease of the bone, and steroid arthropathy. Then another group in the secondary type of this osteoarthritis, which is due to some underlying cause, is group 3, that is abnormal joint laxity, such as Ehlers-Danlos syndrome, osteogenesis imperfecta, and Mohan syndrome. The group 4 include abnormal cartilage growth or function, and there are a lot of disorders such as acromegaly, achondroplasia, spondyloepiphyseal dysplasias, multiple epiphyseal dysplasia, congenital hip dysplasia, mucopolysaccharidosis, ochronosis, or diabetes mellitus. Group 5 includes synovial destruction and of the cartilage and bone, and these are post-inflammatory osteoarthritis, post-infectious osteoarthritis, and hemophilic arthropathy. After saying the long list of the classification of this osteoarthritis, we can infer that there are many local and systemic factors, risk factors, which are responsible for the progression of disease and which determine the site and severity of the osteoarthritis. Age, sex, and ethnic characteristic are linked with this disease. Age is very important phenomena, and as you know that as the age advances, there is increased susceptibility for this disease, and it is an important disease beyond the age of 50. 40% of the cases, 40% of the individuals who are beyond the age of 70 have this disease. Then bone density, estrogen replacement therapy for postmenopausal, nutritional factors, genetic factors, all are attributed to this risk factors of this disease. Local biochemical factors are obesity, joint injury, joint deformity, sports participation, muscle weakness, which decreases the support to the joint. All these are the major risk factors for this disease. So the etiological factor for the osteoarthritis are increased unit load, resilience of the articular cartilage, and stiffness of the subchondral coarse cancellous bone. There are many reasons for this increased unit load. One of the important causes is congenital hip dysplasia, in which the socket of the acetabulum is shallow. It covers only 35% of the femoral head, which is normally covered. 50% of the femoral head is covered normally. So if this less area is covered by articular cartilage, it increases the unit load on the joint articular cartilage, and hence there is chondrocyte death and articular cartilage is degraded. Resilience of the articular cartilage, as we know that there is a large quantity of water within this articular cartilage, and it normally has a swelling pressure of at least 3 atmospheres. Disruption or disturbance of the water content lead to decreased resilience. Then stiffness of the subchondral coarse cancellous bone, as happens in Paget disease, will result in increased unit load in the cartilage and result in the osteoarthritis. The morphological lesion of the articular cartilage results from degeneration or disordered repair of the articular cartilage, which are due to the chondrocyte injury, and this chondrocyte injury is by biochemical stress or genetic pleomorphism, which lead to abnormal signaling mechanism or signaling transduction mechanism, and due to this chondrocyte injury, the protoglycan synthesis is disturbed, as there is continuous formation and degradation of the protoglycan in that area. When there is decreased synthesis and degradation is more, then the protoglycan composition is changed and result in the osteoarthritis. Chondrocyte injury also lead to the TGF beta secretion, and through its secretion the matrix metalloproteases are secreted, and this TGF beta mediated matrix metalloprotease secretion, there is increased degradation of type 2 collagen network. There are other soluble mediators liberated, that are TNF, prostaglandins and nitric oxide also. So there is low level inflammation which contributes to the insidious nature of this disease due to alteration in the matrix. So this imbalance between synthesis and degradation of the cartilage matrix is due to increased degradation by pro-inflammatory cytokines, matrix metalloproteinases such as collagenases, stromycin, gelatinases, aggregationases, prostaglandins or nitric oxidases, and synthesis of anti-inflammatory cytokines, tissue inhibitor of matrix metalloproteinases, growth factors, collagen synthesis and protoglycan synthesis is decreased. Altered by synovial factors or matrix alteration, the chondrocyte, which is linked with cornucopia of matrix element, this chondrocyte is pushed to the plethora of abnormal cellular responses which are made by changes in metabolism or phenotype. Number of cell is also altered by proliferation or apoptosis, and senescence may lead to loss of chondrocyte function. Now if we summarize the pathogenetic event, there are some genetic influences, also some acquired risk factors. The genetic influences are biochemical abnormalities in the collagen, protoglycans and bone formation, or the abnormality in congruity of the joint surfaces, or acquired risk factors such as age, obesity, metabolic condition, malalignment, or joint trauma or injury, which lead to the structural damage to the cartilage. And this structural damage to the cartilage will alter the function of the chondrocyte, as we have seen in previous lecture. This alteration in chondrocyte function will lead to the matrix metalloproteinases release with degradation of collagen and protoglycan. Also, there is muscle weakness present, and both these factors can subsequently further damage, lead to further damage to the cartilage, articular cartilage. These factors will then release the cytokines, and these cytokines will result in inflammation of the synovium or bone remodeling. This bone remodeling can contribute further to the muscle weakness. So injury to the cartilage will result in cracks formation in the cartilage, and there is a subsequent accumulation of the chondrocytes. As a result, there is a release of enzymes which result in matrix breakdown, and due to matrix breakdown, more cartilage is damaged, and this vicious circle continues. Simultaneously, due to release of the cytokines, the synovial membrane is also inflamed, and it also takes its part to the damage of the cartilage, and it is responsible in the change in the chondrocyte also. Cytokines are also responsible for the proliferation of the blood vessels and thickening of the bone formation, and when these more cartilage is damaged, then the chondrocyte they form unorganized cartilage, and this unorganized cartilage subsequently will lead to the osteophyte formation. Prevalence and severity of primary osteoarthritis increases with age. About 4% of the people between the age of 18 to 24 years are affected, while 85% of the people between the age of 75 to 79 years are affected. The disease is more common in men before the age of 45 years, and it is more common in female after the age of 55. In men, the most commonly affected joint is hip, while in female, the more commonly affected joint is knee. So how this osteoarthritis evolves, here you can see a normal joint with healthy cartilage and healthy bone. With the development of osteoarthritis, there is development of cracks initially in the cartilage, which subsequently lead to formation of loose bodies within the joint due to sloughing off of the whole thickness of the cartilage, and the cracks are now more deeper. There is more deepening of the cracks and development of microcyst formation, due to whole thickness loss of the this articular cartilage and subsequent accumulation of the synovial fluid within these cracks, and which deepens and forms cysts. Joint capsule is affected lately. So finally, the bones in the joint can seriously and permanently deformed, and there is loss, almost complete loss of articular cartilage. So now histogenesis of the this osteoarthritis. In the left diagram, you can see that some of the chondrocytes are dead, and this death is marked by empty lacunae on the outer and surface of this inner cartilage or joint surface of this articular cartilage, and as a result, the surrounding chondrocytes, which are viable, they aggregate, enlarge, and they now become surrounded by the basophilic material, which is termed as territorial matrix. The process can be arrested at this stage for several years, but as the predisposing factors are there, so it can lead to the next step, which is the formation of early cracking and fibrillation. In fibrillation, there is development of surface cracks parallel to the long axis of the articular cartilage. Still, it is limited to the area above the tide mark. As the fibrillation progresses, there is loss of the articular cartilage, and this articular cartilage can go to the synovium and start an inflammatory reaction in the synovium. And now this defect or this crack is vertical in the long axis of the perpendicular long axis of this articular cartilage, and due to this defect, there is hypertrophy of the adjacent chondrocyte, as we discussed earlier, and now this defect is going down, and it has gone beyond the tide mark and whole thickness of the cartilage, and this cartilage, the removed cartilage, can go into the joint as a loose body, and the bone is also resolved due to some of the part of the bone is also started to resolve due to osteoclastic activity. And as you know, there is a simultaneous osteoblastic activity there, and due to these activities, the underlying bone is going to be thickened. What happens next when there is vascularization of this area? There is accumulation or infiltration by the mesenchymal cells, and these mesenchymal cells then differentiate into fibrocartilage plug. The fibrocartilage is unstable mechanically, so it disappears progressively, and the underlying bone is exposed, and this underlying bone is thickened and evernated. If there is any crack in the bone, there is leakage of synovial fluid, which initiates the formation of subchondral bone cyst formation. Focal regrowth of articular surface will result in osteophyte formation. The osteophytes, which are also termed as spur, are pearly grayish white bone nodules, usually on the periphery of the joint surface, and formed by differentiation of the mesenchymal tissue into the osteoblast and chondroblast. They produce characteristic lipping pattern on radiology. The osteophyte of the distal interphalangeal joints are termed as Haberden nodes. All these pathogenetic events then lead to characteristic morphology of the osteoarthritis, that is fissured or crack formation, presence of loose body, hibernation of the joint surface, formation of microcyst, presence of osteophyte or synovial changes. The chondrocyte proliferation, decreased proteoglycan, increased water and collagen type 2 degradation result in granular and soft articular surface. Loose bodies are formed due to full thickness sloughing of the cartilage. Then hibernation is due to friction. This joint surface, exposed joint surface, is now hibernated, and it is shiny articular surface basically. Microcysts are formed due to collection of the synovial fluid within due to formation of gap and small flexures inside. And the osteophytes we have earlier discussed, these are the mushroom shaped bony outgrowths at the margin of the outer surface, and these are capped by fibrocartilage or hyaline cartilage, and these cartilaginous tissue ossify gradually. Synovium is involved lately in the osteoarthritis, and if seen, it is mildly congested, fibrotic, and it contains few inflammatory cells. This is the gross appearance of the joint articular surface, which is showing hibernation. There is on your extreme right, there is some remnant of the articular cartilage, and two evident subchondral cysts are present on the upper field. These illustrations are showing the summary of the morphological changes due to osteoarthritis. The articular ends become flattened, the cartilage is damaged, the joint space becomes reduced, frequent presence of osteophytes or bony spurs, presence of loose body which results in crepitus formation, and then the microcyst formation, which is subchondral bone cyst. Two histological characteristics of cartilage in osteoarthritis are fibrillary fissuring and clustering of the cell in superficial zones. This histological picture from femoral head is showing the presence of fibrocartilaginous plug and hibernation of the bone. So this photomicrograph of the head of the femur is showing that there is thickening of the subchondral bone, focal absence of the articular cartilage, and in that area there is a presence of subchondral bone cyst. So these changes are evident by the radiology, as this X-ray is showing the hip joint with narrow joint space, subchondral sclerosis, scattered oval cysts, and peripheral osteophyte lipping, which is marked by this arrow. And this is a knee joint with narrow joint spaces, subchondral sclerosis, and lateral osteophyte. The patient of osteoarthritis is usually an old age man or women. If the signs and symptoms are present in the younger individuals, the underlying cause for the osteoarthritis must be sought. The symptoms can be mild or severe. The joint is enlarged, tender, and boggy. It is painful, and there can be knobby, bony growths present in the finger, and loss of cartilage in the joint will result in pain, which is deep, achy pain. This pain it will get worse with the moment. There is morning stiffness in the joint, but it relieves after some time with activity, and there is swelling of the joint also. Then there are effect by the osteophytes, in which there is nerve root compression, which result in radicular pain, spasm of the muscle supplied by that particular nerve, atrophy of the muscle, or neurological deficit. Then there is limitation of the joint movement. Joint deformities develop over time, but fusion usually doesn't occur. The commonly affected joints are hip, knee, lower lumbar and cervical vertebrae, proximal and distal interphalangeal joints of the finger, first carpometacarpal joints, and first tarsometatarsal joint. The few joints of the body are spared from this osteoarthritis. These are wrist, elbow, and shoulder. For the treatment of the osteoarthritis, the aim is to manage the pain by non-steroidal anti-inflammatory drugs, which reduce inflammation. Also, intra-articular corticosteroids are also used. Modification of the activity by the person, and if this joint osteoarthritis is disabling, then arthroplasty can be performed. There is no way to prevent this disease, but it can be delayed by the increasing the support to the joint by the physical activity, which increases the strength in the muscle around the joint to stabilize them and to move the joint or to their full extent, and decrease the workload or unit load on the joint. Neuropathic joint diseases of Charcot joint was described by Jean-Martin Charcot in mid-19th century, who described destruction of knee joint in patient with Davis dorsalis and termed it as Charcot joint. It is basically a form of non-inflammatory arthritis, which is characterized by progressive joint destruction due to a primary neurological disorder such as peripheral neuropathy or central motor abnormality. These days, the commonest cause of this neuropathic joint disorder is diabetes mellitus, following the peripheral neuropathy. In syringomyelia, there is destruction of shoulder and other upper extremity joint, and this Charcot joint or neuropathic joint is considered a rapid and severe form of secondary osteoarthritis, which is associated with joint fragmentation. What happens in this osteoarthritis? There is loss of innervation of the joint structure, and due to this loss of innervation, there is lack of proprioception and pain. So the joints mechanic are now abnormal, and as a result, there is destruction of the joint. Microscopically, there is marked destruction of the articular cartilage and subchondral bone. There is subchondral sclerosis, cyst formation, and it is characterized by large amount of cartilage and bone detritus within hyperplastic synovium. The case we discussed in the start of this lecture on physical examination showed bilateral swollen knees with mild joint effusion and crepitus with flexion. So there are nodules on the distal interphalangeal and proximal interphalangeal joints also, and X-ray showed reduced joint space and presence of osteophyte. So I guess it's now easier for you to label this case.